All right, welcome back to the deep dive.
Good to be here.
Today we're tackling a specific topic, one that definitely pops up in medical revision.
Hmm.
We're using a set of focused study notes, and the condition is paratyphoid fever. Often mentioned, maybe less understood than its more famous cousin, typhoid.
That's right. They're often grouped together.
So our mission today, let's unpack the essential high-yield stuff about paratyphoid. We want to distill these notes, make it clear, make it memorable.
Also for revision, yeah.
Exactly.
Yeah.
Help you grasp the key concepts quickly, make it stick. Think of it as, a shortcut to understanding the crucial bits.
Good way to put it.
So if you're maybe grappling with tropical diseases, trying to get a firm grip on this for exams, or maybe you're just curious, you're definitely in the right place.
Absolutely.
Okay, let's unpack this then. What exactly is paratyphoid fever? Let's start with the definition.
Okay, so paratyphoid fever, it's essentially a systemic infection.
Systemic, right.
Yeah, affects the whole body.
Right.
It's caused by bacteria, Salmonella, enterica, but specifically the serotypes Paratyphi A, B, and C.
A, B, and C. Got it.
And the really critical thing to grasp right up front is how similar it is to typhoid fever.
How so?
Well, in terms of how you get it transmission, what it looks like clinically, the symptoms, and even how it's managed. Very, very similar.
Okay, so same bacterial family, Salmonella, enterica, just different specific strains, the Paratyphi A, B, C ones.
Exactly.
And that leads to this very comparable illness. So how do these Paratyphi strains actually get into the body? What's the cause, the etiology, and how does it spread?
Right. The main way it spreads is through ingestion. You basically eat or drink something contaminated with the bacteria.
Okay.
It's that classic fecal-oral route. The bacteria live in the intestines of infected people, and they get shed in their feces.
And that directly links to sanitation, doesn't it?
Precisely. That's why poor sanitation, inadequate hygiene practices, and consuming unsafe food or water are the absolute main drivers of how this spreads.
Makes total sense. So given that route, who's most likely to get it? Who's vulnerable? What are the key risk factors we should remember?
Well, as you'd probably guess, the risk factors look a lot like those for typhoid fever.
Right.
So anyone living in, or importantly, traveling to areas with poor sanitation, limited clean water access, they're at higher risk.
Travel's a big one then.
A very big one for places like the UK. Also, directly consuming contaminated food or water, obviously, and close contact with someone who is a carrier. Maybe they don't even know they are.
Oh, okay. Carriers.
Yeah. And then there are some jobs that increase risk. Healthcare workers, people handling food, lab workers dealing with salmonella.
Okay, that paints a clear picture.
Yeah.
Now, this is where, for me, it gets really interesting. Once someone ingests the bacteria, what actually happens inside? Can you walk us through the pathophysiology?
Sure. So after you swallow the bacteria, they don't just, pass through. They invade the lining of your intestine.
Okay, breach the barrier.
Exactly. And then they get taken up by these immune cells called macrophages.
Ah, the body's own cells.
Yeah. But the bacteria kind of hijack them.
Yeah.
These macrophages then carry the bacteria through the bloodstream, distributing them around the body.
So that's how it becomes systemic.
That's right. They can end up infecting organs like the liver, the spleen, even the bone marrow.
Wow.
And the body's immune system obviously fights back, causing inflammation, which can lead to tissue damage in those areas.
And what about transmission? How does it get back out?
Ah, good point. The bacteria can also invade the gallbladder. They can multiply there, get excreted in bile back into the intestine.
And then shed in the feces to potentially infect someone else. Completes the cycle.
Precisely. And again, this whole process, remarkably similar to typhoid.
So similar path, similar organs affected compared to typhoid. It sounds like telling them apart just by symptoms would be, well, difficult.
Extremely difficult, yes.
So if someone comes in with this kind of general systemic illness, fever, feeling unwell, what else needs to be on the list? What are the differential diagnoses?
Yeah, that's a crucial point for revision. The differential list is broad because the symptoms are non-specific initially.
Right.
Obviously, typhoid fever is number one on that list. You have to consider it.
Naturally.
But also, think about viral infections that cause similar symptoms, like dengue fever, especially with travel history.
Okay.
Other bacterial infections, too, even different types of salmonella, the non-typhoidal ones, they can cause gastroenteritis, but sometimes more invasive disease.
Sure.
And don't forget parasitic infections like malaria, again, vital if the person has traveled to an endemic area.
So the takeaway is clinical picture alone isn't enough. You need tests.
Absolutely. You need those investigations to confirm.
Okay, let's think about context. The notes mention an MSRA focus, often UK-based revision. How common is paratyphoid here In the UK, for example, what's the epidemiology look like?
Yeah, in a place like the UK, paratyphoid is, relatively speaking, uncommon. Most cases we see are imported. They're usually linked directly to recent travel to regions where the disease is endemic, parts of Asia, Africa, Latin America.
So travel history is key.
Crucial. Or sometimes it's close contact with someone who traveled and brought it back. So international travel, migration, these are the main factors influencing the numbers we see in non-endemic countries like the UK.
Right. Okay, let's bring it back to the patient then. What would someone actually, look and feel like if they had paratyphoid? The clinical presentation, what are the key symptoms?
The absolute hallmark symptom is the fever.
The fever.
Yeah, and it's characteristic. It tends to start gradually, maybe creeping up over a few days, and then it becomes sustained high. And it can last for weeks if it's not treated.
Weeks of fever. That sounds debilitating.
It really is. Alongside that, common symptoms are things like abdominal pain, a nagging headache, just feeling generally unwell, malaise, loss of appetite, anorexia, and body weakness.
What about bowel habits, often a key feature in gut-related infections?
Good question. It can vary, but the notes highlight that constipation is actually more common than diarrhea in paratyphoid.
Oh, interesting. That's maybe counterintuitive for a Salmonella infection.
It is a bit, yeah. Worth remembering. Early on, symptoms might be even vaguer chills, sweating, maybe a dry cough, sore throat, dizziness, muscle aches, very nonspecific stuff.
Okay, so lots of general symptoms. Are there any more specific, maybe distinctive signs? Things that are really high yield for revision?
Yes, there are a few classic signs to look out for. One is called relative bradycardia,
Relative bradycardia.
meaning the heart rate is slower than you'd expect it to be for someone with such a high fever. Normally, fever makes the heart race, right?
Right. Pulse goes up.
But in enteric fevers like typhoid and paratyphoid, the pulse might be inappropriately slow for the temperature. It's a classic, though not always present sign.
Okay, that's a good one to flag. What else?
Hepatosplenomegaly. That's enlargement of the liver and spleen. You might be able to feel them on examination. It reflects that systemic spread we talked about.
Okay, liver and spleen enlargement. Makes sense. Anything else?
And then there are the rose spots.
Rose spots. Tell me about those.
These are small, faint, pink, or rose-colored spots. They typically appear on the abdomen and chest, usually in the second week or so. They're transient, meaning they come and go, and they tend to blanch when you press on them.
Blanching rash. How common are they?
They're seen in maybe about a third of patients. So not everyone gets them, but if you see them in the context of this kind of illness, it strongly suggests an enteric fever.
Rose spots, relative bradycardia, hepatosplenomegaly, those are like key things to remember.
Definitely high yield.
Maybe a quick memory aid. Someone suggested fever and the 4 Ps. Fever, obviously prolonged. Then pain, abdominal, prolonged fever, okay, repeating fever. Pale spots, rose spots, and pulse, relative bradycardia.
Yeah, a bit rough, but if it helps anchor those key features, why not? Pain, pale spots, pulse, and prolonged fever.
Worth a try. So these signs are helpful clues, but you stressed earlier you need specific tests. How do doctors actually confirm it's paratyphoid? The investigations.
Right. Confirmation relies on finding the bacteria or evidence of them. The gold standard, particularly early in the illness when bacteria are in the blood, is blood cultures.
Growing the bacteria from blood.
Exactly. You're trying to isolate Salmonella paratyphi directly. Later in the illness, or for finding carriers, stool cultures become more useful.
Okay. What about other types of tests?
There are serological tests, like the Weddell test you might hear about.
Yeah.
These look for antibodies the body makes against the bacteria.
Are they reliable?
They have limitations. Sensitivity and specificity can be issues, especially early on, and interpretation can be tricky. Increasingly, we use molecular assays like PCR, which detect the bacteria's genetic material, DNA or RNA. They can be faster.
So blood culture is key, stool culture later, serology maybe less so, and molecular tests are emerging.
That's a good summary. And the goal of these tests isn't just diagnosis, it's also to work out which antibiotics will be effective. Susceptibility testing is vital.
Ah, good point. Which leads us neatly to treatment. If someone gets that confirmed diagnosis, what's the management plan?
Again, the management plan is very similar to typhoid. The absolute mainstay is antibiotics.
Which ones typically?
Well, fluoroquinolones like ciprofloxacin have been common. Third-generation cephalosporins like ceftriaxone are also used, especially for more severe cases or known resistance.
Resistance is a factor then.
Oh, absolutely. Salmonella resistance is a significant global problem, so you can't just guess. You really need those lab susceptibility results to guide the choice.
Makes sense. What else besides antibiotics?
Supportive care is crucial, making sure the patient stays hydrated, managing the fever and pain with things like paracetamol, and ensuring they get adequate nutrition because, as we said, it can be a prolonged, draining illness.
Right. Any specific UK guidelines?
Yes, national or local guidelines will provide specific antibiotic recommendations, often based on likely travel destination and local resistance patterns.
And vaccination. Is that an option?
There's a vaccine for typhoid, but not routinely for paratyphoid. It might be considered in some very specific high-risk scenarios, perhaps, but it's not standard practice.
Okay, antibiotics and supportive care are key. Finally then, what's the outlook? If someone gets treated, what's the prognosis? And what are the potential dangers if things go wrong, the complications?
So the good news is, with timely and appropriate antibiotic treatment, the prognosis for paratyphoid is generally very good. Most people make a full recovery.
That's reassuring.
However, and this is important, complications tend to happen when there's a delay in diagnosis, or if the treatment isn't adequate, maybe due to resistance.
And what kind of complications are we talking about?
They can be serious, and again, similar to severe typhoid, things like intestinal perforation, basically. A hole developing in the bowel wall, that's a surgical emergency.
Wow, okay.
Significant gastrointestinal bleeding. Problems with organ function, like hepatic dysfunction, liver, or renal dysfunction, kidneys. And in the worst cases, overwhelming infection leading to sepsis.
So potentially life-threatening issues if not caught and treated properly.
Definitely. Which really underscores why early diagnosis, appropriate treatment based on susceptibility, and good follow-up monitoring are so important. Prevent the complications, ensure complete recovery.
It all ties together. The similarities to typhoid are striking throughout transmission, symptoms, even the serious complications.
They really are. Which leads to an interesting thought, perhaps. Given these huge similarities in how they spread, how they present the pathophysiology, it really highlights how crucial those specific diagnostic tests are to actually tell them apart. It makes you wonder, doesn't it? What are the subtle, maybe molecular differences between Salmonella typhi and Paratyphi that mean we need these specific tests, even when they look so similar clinically?
That is a fascinating point. What differentiates them at that deeper level despite the clinical overlap? Something definitely worth pondering further. We've covered a lot of ground there.
We have.
Definition, the cause and spread, risk factors, what happens inside the body, what else it could be, the UK picture, those key symptoms and signs, especially the high-yield ones like rose spots and relative bradycardia.
How to diagnose it with tests, the treatment approach, and the outcomes and potential complications.
Exactly. We really hope this deep dive into paratyphoid fever, drawing from those key revision points, has helped clarify things and made the essential info more memorable for you listening.
Hope it's been useful.
Thanks so much for joining us. And if you are revising and found this helpful, you might find even more value over at passthemsra.com and freemsra.com. Definitely check those out.
Great resources.
Until next time.